as expected, relatively old. So these women are 36 and with a little bit better ovarian reserve, still 35, with a duration of infertility close to 3 years. So what happened in the first cycle, that if you increase your dose to 225 or 450, then you get a better response. So you see less poor response. You retrieve more oocytes. Overall, you have less poor response. You transfer more embryos. You freeze more embryos. But if you come to the live birth, there is no difference. And my reading of that is that the extra stimulation creates an extra number of eggs that are actually not going to result in a better pregnancy rate. So if we looked at the cumulative pregnancy rates, then there was also no difference. So these groups came to around 43%, 45% over multiple cycles. As you can see here also, and the cumulative curve basically doesn't show any difference. So the important message here is, whether you work public or whether you work private, I think that putting a lot of money in extra gonadotrophins, certainly above 300, is probably a waste of that money, and you better keep your money in your pocket or in the pocket of the patient to allow a future cycle. So individualized dosing for poor response, less cancellations, more oocytes, no increase in normal response, and importantly, no increase in live birth rates. Then to the other side of the spectrum, the hyper responders. So this is a bit off topic because I'm supposed to talk about ovarian aging, but still important, I would say. So here we randomized for 100 going low versus 150. Not much differences in terms of live birth rate. Again, 25 versus 25%, but definitely on the 100 side a little bit more safer. So you see that hyper response reduced from 38% to 11%. There is a little bit poor response in this category. And there is a reduction in OHSS from 11 to 3%, although that is the mild OHSS and a limited effect on the severe OHSS. Cumulative ongoing pregnancy rates higher than in the other category. So this is the good prognosis group, as high as 70%. And you can see here, so on the right, the one that I showed, earlier, and on the left, the better response group. Interestingly, this was very controversial. I mean, I love to do research and create data, but this paper created an enormous amount of response in terms of letters to the editor from our colleagues, because nobody actually likes that statement that increasing the dose is not effective. One thing important, and I want to mention that we have not published this, but in the hyper response group, actually the group who has the higher dose, so the 150, has a higher second live birth rate. So here you create more oocytes, more embryos, and you create a larger family, so to say, in 15% of the patients, as compared to only 7% in the group that treated with 100. So this is a little bit safer, but this creates more embryos and therefore more children. My personal preference is on this side. I think that the rate is about 1 extra child and 1 extra cage of OHSS. I would say that many couples and women make that trade-off. So having done these studies, you want to reproduce, and there was a fantastic opportunity in China, in the Northwest Women's and Children's Hospital, a clinic led by Professor Jianshui Shi, And this study was done by Liu Xitong, who basically repeated the Optimist study, but then in the Chinese population and only the poor response side. So again, expected poor response, standard dose, or increased dose. We went as high as 300 here. Interestingly, here in China, the live birth rate in the increased dose was a little bit higher. So that didn't reach statistically significant, but it was very borderline 0.07. And I have kind of difficulty interpreting these data as compared to the data that I show from the Dutch studies. But I'm inclined to believe maybe that the response in Asian or Chinese patients is different. So here you see that difference. There is clearly a higher live birth rate from standardized dosing. And then to a series of studies done by another group. So this is around, call it alpha individually versus conventional dosing. The studies done by Anderson from Denmark and Scott Nelson. So a very similar design as the Optimist studies, but the drug here was follistatin delta versus follistatin alpha. So a little bit different drug, Recovel, and also individualized dosing in this algorithm against standard dosing. So in this European ESTER study, there is no difference in live birth rate, but again, in the higher hyper-response ranges, so the higher AMH ranges, there is an advantage of individualized dosing an advantage in terms of reduction of OHSS. So this group supported by Ferring has repeated their study also in Asia. So this is work led by Professor Zhao Ji from Beijing, but also with support from recruitments in Vietnam and other places. And interestingly, here, the dose adjustment also results in higher live birth rate. So realize what I've just shown. Dose adjustments in the Optimist studies in Europe, no benefit. Bring it to China, benefit. You have the ESTER studies from Ferring around follistatin alpha. In Europe, no increase in live birth rate, but here in Asia, again, an increase. And that is what puzzles me, whether potentially the profile of the Asian or the Chinese patient could be different from that in Europe, which is in itself very important to understand because it obviously will influence our interpretation of studies. In that study from Zhao Ji, also that protective effect from individualized dosing in the expected hyper responders. So a couple of comments on meta-analysis. Cochrane has done meta-analysis. We have published this Cochrane review this year. But the problem is that if you have the studies that randomize the algorithm and the studies that randomize the dose after you have classified the hyper and poor responders, do not allow adding up the data. So each individual meta-analysis has a very limited number of studies, as you can see here. And if you're going to look at the dose algorithms, then you can't separate the hyper and the hypo responders. So what we have done is individual participant data meta-analysis, and these data have not been published yet. But we have written to all these authors, obtained their raw data, and then we separated the expected poor and the expected hyper response group. In the expected poor response group, dose adjustment reduces your poor response rate. So you're going to have less patients that you have immediately disappoint. sent home without a transfer, etc., etc. But it doesn't result in a higher live birth rate. So the live birth rate from individualized higher dosing in poor response, also in the meta-analysis, and also if you look at ongoing pregnancy rates and clinical pregnancy rates, is not different. So one of my key messages of this lecture is stay away from doses at least higher than 300 units, but potentially even higher than 150 or 225 is not going to bring you benefit. A lot to do about add-ons. There's going to be a review published soon in Fertile Sterile, not published by me, so I can't say it, but I have dealt with it as an editor. And that meta-analysis is going to suggest that testosterone might be an add-on that's helpful. This is work that we're doing ourselves. Growth hormone as an add-on in women with poor ovarian reserve. The trustworthy studies that we find suggest a benefit from growth hormone. I think these needs more RCTs, but growth hormone is potentially a good add-on in women with poor ovarian reserve. And then my last message that is very important, we have looked into natural conception rates among women over 35 years who were treated for infertility. And these rates, if there is no other diagnosis, so here you see in all the colors, women with anovulation, male factor, tubal factor, then the prognosis is really poor. But if it is apart from the age unexplained, then the 1 year cumulative pregnancy rate is actually 20%. And I think it's really important to share with your patients that they shouldn't give up. They should not have false hope, obviously. You should not say, oh, it's always going to be all right with you, because that's not the case. But for couples to just miss out on their monthly opportunity if there is still a regular cycle, I think that's a missed opportunity. And this is the curve that we created in this paper, going after 1.5 years as high as 25%. So that's really an important message. I'm going to close. Predicted poor and hyper responders, 2 important categories. Poor responders, dose increasement to super high doses of gonadotrophins. I think it's potentially a waste of money. Do mild stimulation and do multiple cycles if needed. On the hyper response side, you can decrease the dose, prevent OHSS, but realize that you reduce the number of embryos and therefore the chance of a second cycle, of a second chance, a child from the same cycle. And with that, I give back to the chair. And thank you very much again for this opportunity.
Thank you, Dr. Ben. I mean, that was really wonderful. And I think you've given some really good insights. Don't increase more than 300, because all of us tend to just, use more gonadotropin. And thank you for that note on, kind of validation of growth hormone, because, people are using it. So I think it's really good. Yeah, you want to add something?
Well, I don't know. I mean, I think if people are using it, I'd like to hear from their experience. And it's also a topic that needs more research, I would say. And if I growth, I think if you could organize a company that is interested in providing this medication and placebo, that would be a super good study. And the other important message is we need separate studies in Asia, because I'm really puzzled by this different result from the studies from Jiaoji and from Xi'an as compared to the European studies. If you would completely go with the European studies, you would ignore this potential effect. So that's really important.
So I think maybe, I can make a request to Dr. Budi Viveko that we can do something from AOFOG and, try and mobilize a kind of a multi-centric trial from from Asia. Thank you very much, Dr. Ben. Enlightening presentation, and of course, it enhances and advances our understanding of ovarian aging. Now, I think let's see if there are any questions in the chat box. Yeah, I have to access
in the Q&A column. Yeah,
it.
there's eight questions.
Hold on. Yeah. Sorry. Thank you, Dr. Budi. The first question is to Dr. Harada. Can you tell us about the standard of PRP concentration you're looking for? That is question number one. Question number two, what is your suggested protocol of PRP in thin endometrium? And also, I need to know if you have a space for international fellow to gain from a valuable experience. Thank you so much. This is Dr. Amar Azavi.
Thank you for your question. To be honest, I'm very suspicious about PRP. Although I presented about the PRP injection in the ovary. So actually, in our country, that PRP injection in endometrium, in uterus as well as in ovary, is not much conducted in our country, and especially in the PRP injection in the ovary is accepted as a very experimental. So I cannot tell that standard concentration. I'm sorry about that. And in the literature, there as I presented the protocol, I mean the concentration and volume and how many times and how many volume is very different between study to study. So I cannot conclude which concentration and volume is appropriate to do PRP injection in the ovary. And regarding the PRP injection in the uterus, of course, we very sometimes to do that, but as reflected in the Cochrane review results, in the same Cochrane review, this Cochrane review, as I introduced in my lecture, is not only regarding to the PRP injection in the ovary, as well as in PRP in ART. So they also have their summary results of the PRP in the uterus. But they also concluded that they are not sure it is effective in that to promote the pregnancy. And I totally agree with that conclusion. And that's my answer. Thank you very much.
Thank you, Dr. Harada. I think the next question is for Dr. Budi Viveko. Nusrat Mohammed from Bangladesh. Do you think ethnicity and race may have an influence on ovarian aging?
Yeah. Thank you, Dr. Nusrat. So I think it's quite interesting to see how the ethnicity and also race may have influence on ovarian aging. Even we look the review how the genetic is quite important, including the epigenetics, environmental, and then also the cellular mechanism involving in making the ovarian aging. But if you look into details, the genetics problem that induce ovarian aging most likely is there's a problem with the gene who involving in the gonadal functions, such as maybe the very famous gene, fragile mental retarded 1. If there is a mutation in fragile mental retarded 1 gene, there will be a problem with the ovarian function, and also in other gene that is responsible for gonadal functions, such as the SF1, SOX9, SRY. So most likely that is gene that have a responsibility to gonadal function. It's not talk about the race and ethnicity. Thank you.
Thank you, Dr. Budi. Yes, and we had an Indian paper which actually said that Indian women age 7 years earlier than their Caucasian counterpart. So yes, This, Dr. Benmol, you have a question. Do you have any preference to go for recombinant FSH or recombinant rec FSH or rec FSH or FSH alone?
Um, I don't know. I wouldn't go too expensive. I would just uh, if you want to drive from A to B, and you can choose to do that with a Toyota Corolla or a Mercedes-Benz 450 SLE. They both bring you from A to B. So I mean, if your patient is able to afford themselves a Mercedes 450, you can do that. But in general, I would say patients have to save a lot of money before they can allow a cycle, and I would keep that cycle relatively cheap, so to say.
Okay, but what about HMG? When do you prefer FSH to HMG or vice versa?
Well, no, I would say the big question again for ovarian aging is the addition of LH. That is another add-on that has potential and need more studies. But I would just go with a good protocol that you standardize in your clinic in the relative or cheaper gonadotropins. So I wouldn't go for the rec FSH for everyone.
Okay, thank you, Dr. Mo. Indra here has a question, has a first statement. A very good presentation, Professor and Dr. Harada. I have two questions. I would like to ask Professor Budi Viveko and Dr. Miyuki about PRP. As stated, intraovarian PRP having a mixed review. When do we give intraovarian PRP in women with aging ovaries? And the second question to Dr. Harada is, what is your opinion about SLE? Let's let Dr. Budi answer, then I will ask the question to Dr. Harada.
Yeah. Thank you very much, Dr. Indra. So I think, as previously mentioned by Dr. Harada, the role of AMH in the injection intraovary still insufficient evidence. I think it's quite premature if we state that the PRP has a significant result for patients with POI or patients with premature ovarian menopause, or premature ovarian insufficiency. But I think the role of PRP in the experimental in animal study looks promising, as they also that PRP in our study, in experimental study, PRP looks increasing the expression of FOXO3 in the granulosa cell of animal study in the mice, and also increasing DDX4 expression. It means that related with organelle stem cells. But for the clinical part, it still need a lot of evidence. There is still insufficient evidence. Also, the standardized of PRP, how the concentration, how the methods to make a PRP still lack of standard. Thank you.
Yeah, I think you're very right about the lack of standardization. In India, there's a company which is saying artificial intelligence equipped PRP they're preparing, and they're giving it in different phases of the cycle: the follicular phase, the ovulation, and the luteal phase. So I think there is a lot of things going on which we need evidence for. Dr. Harada, what is the same Dr. Indra is asking you, what is your opinion about SLE and relationship with POI, and also with the level of AMH? Is there an excessive recruitment process on SLE patient, or is it due to damage or mutation in AMH? If Dr. Harada has a good idea for research related to SLE, POI, and AMH, what can we try to check?
Okay, thank you very much. It's a very difficult question. And I think that the mechanism that SLA, the POI in SLA or autoimmune disease patients would be very, very different, or I mean, maybe multiple factors affects the ovarian reserve, because sometimes we experience that even though the AMH is high, but the patients experience POI. But some patients POI with very low AMH. So one expected mechanism would be that even though the ovarian pool, I mean, the number of primordial follicle is sufficient, but some kind of antibodies for anti-ovarian antibody would perturb the ovulation or follicular growth. That might be one mechanism. But if the patients experienced a very low AMH, it would be that the mechanism would be that the injury for ovary itself, it might be because of that cellular senescence, like chemotherapy-induced POI or something. I mean that adverse follicular microenvironment stem from that autoimmune diseases might cause that might decrease the ovarian function. So it is a very, I think I expect that it is a very, very complex state. I mean, heterogeneous status in the ovary is occurring in these kind of patients. That is my expectation. Thank you.
Thank you, Dr. Miyuki. Jason Tangari is asking from Indonesia, very good webinar by the REI committee. I would like to ask Professor Ben Moll, is FSH dose related to AFC? If so, what is the optimum starting and total FSH dose to increase IVF success?
I would say the starting dose is 150. And then you go for the individual response of the patient. So I'm glad with the question, because what I can clarify is that the studies that I showed are not 150 once and forever, but they are start with 150 and then see what the response of the patient is and adjust in the next cycle, but based on the response, so to say, and not based on an algorithm upfront. The other thing I can say, with recent data from, again, China, because they're so big, is that the individual poor response in somebody who has a normal profile or relatively normal profile should not lead to panic. That is just bad luck. So the data show that if you have a normal ovarian reserve profile, AMH, AFC, normal age, etc., and you have a poor response one time, the next time you're probably going to do okay. It's the patient profile in terms of older age, low AFC, low AMH, higher FSH, that is the problem. So if you have that and you have a poor response, then you're in more trouble. But substantial dose increasing as a routine is not going to help you. And my reading of it, but that's interesting also in relation to the more fundamental work of the other speakers, is that the extra eggs that are there and that you mobilize are actually of poor quality. So it's a little bit about squeezing the lost water out of something that's not going to help you. That's going to not give you more drinking water, so to say. And I very much believe much more if you do IVF in a repeated number of cycles, try to get the best egg each time, rather than squeeze the maximum out of it and then give up.
Also, I wanted to ask you something, that does the excessive hormone that we use have any detrimental effect?
Well, for your wallet. No, I don't think so, because I mean, the other day, I don't think that I showed that clearly. So OHSS is just not a problem in this category, right?
Any detrimental effect on oocyte quality? There are a lot of papers which did come.
Yeah, I don't know. I think if you create more embryos and more oocytes to handle, that complicates the job for the embryologist and the lab. And as I show, or as we show, or as the data show, it doesn't increase your live birth rate. So you make everybody more busy. with material that is never going to result in a baby.
Okay. Thank you. Okay,
Yeah.
Dr. Natasha from, please let me know if the time is okay with all of y'all. Dr. Natasha from Indonesia, Professor Budi Viveko, as globalization occurs, the incidence number of premature ovarian insufficiency has increased significantly. How do we suspect POI in adolescents? That's
Yeah, I think this is a very interesting and important question. Of course, the very clinical practice that we can use to detect early detection of POI in adolescents. Number one, of course, we should explore the menstrual regularity of the menstruation of the patients. If the patient suffering from primary amenorrhea, it's very easy for us to see how the secondary sexual characteristic is it retarded or not, something like that. The assumption that the patients have a very low estradiol if the sexual secondary sexual characteristic is retarded, then it must be happening in the gonad most likely. But the more difficult one if the patient having the menstruation, the menarche, and then maybe several years later, suddenly she stopped her menstruations. So that's why this is the very hard homework for us to follow, to educate the women to make a diary of menstruations monthly is very important. How are the cycles and how many days, how long the menstruations. And then, of course, if we have a patient with the secondary amenorrhea, please explore, please do the investigations comprehensively. What is the cause of the secondary amenorrhea? Amenorrhea is because of the aneuploitation. And then what is the cause of aneuploitions? It is because of the ovarian reserve, the diminished ovarian reserve, or others. It's very important. Then I think it's quite related if we think about the ovarian reserve in the first place after we exclude all the abnormalities, including the pregnancy, thyroid function, prolactin, PCOS, or something like that. Thank you.
Thank you. Oh, I've lost that. Hold on. Yeah. Okay, that was a difficult question. One question from Sarah, Indonesia. I would like to ask Professor Ben Moll that as stated in your presentation, giving folitropin alpha have different outcome in European and Chinese populations. So how do you predict and prevent OHSS in different populations?
Good question, but I don't have good data on that. So we did this study in Xi'an only in the poor response group and not in the hyper response group.
Okay.
So I can't answer that. And then the folitropin alpha, so the fairing studies do not provide enough insight in what happens in each of the groups. But in general, I'm convinced that we should, and it's a very sensitive topic in the modern world because you can't. Yeah, right. As soon as you touch upon ethnicity, you're a racist or whatever. But I think we should realize that the biology of people around the world is probably completely different, right? If we take it to duration of pregnancy, then we know that black women or African women or how you want to name it have a shorter duration of pregnancy than women in other areas of the world. And that is very important because that means that their definition of prematurity, their survival rate of early born babies, but also, and even more important, what happened on the other end of the spectrum, being post-term, etc., goes through different definitions. Another example is here in Australia, we see an increased mortality stillbirth of South Asian women who go beyond 41 weeks, and I'm convinced that their biology is just different from the Australian women. And if we don't acknowledge that, we just do short, and that is probably the case also in reproductive medicine. So we really need data also from individual countries to compare how we're doing. I think it's a mistake to completely go to studies that are done in one area of the world. I mean, I'm with a very good PhD student at the moment, Feng Chen. We are looking at the distribution of reproductive medicine RCTs around the world, and areas like South America or Africa just don't supply any data. So it's very difficult to come up with an individualized management. And that's, I think, where is a great, I mean, how many people do we have online? 123. It's a great opportunity, and not necessarily through RCTs, but to share outcome data in different countries and try to understand differences that we see.
I think you brought about a very important point, highlighted an important point that we really need data to individuate. This is another question which actually even my assistant asked. There's a lot of patients, normal responders. We start with 225 and they don't respond. We have to increase. So what do we do in this kind of a patient? They're not responding. Cynthia from Indonesia.
So I think that you're doing the right thing by don't starting too high, or maybe even 225 is a little bit too high. The other thing I think is communication to the patient, what the expectations are. What I do, if somebody with a poor response start, I say, well, we're going to try it, but realize that if there is again a poor response, this is your last time, and you have to accept it. And I think that communication up front is very important, because that allows, although it's difficult, that allows the couple to manage the decision that they have to stop, so to say. And in our country, then oocyte donation is an opportunity. It's not easy, but I think at some stage that is really the way out if the response is really poor. And that is a much more rational thing to do than to continue with cycles that are not going to result in a baby.
Okay, thank you. Dr. Miyuki, what do you think about stem cells or secretome treatment in POI? This is by Stella Mansoor.
Thank you, Stella. It's my very personal opinion, but that I think the stem cell would be more effective or more effective than PRP, I feel, because of course I'm not sure about that POI, but as for that pin endometrium, I think that stem cell would be better than PRP. That's my feeling, but it's just a feeling. So we need evidence. Thank you.
Thank you. Thank you. This is a repetition, actually. William Vahono. At what age do you think we can really start doing serum AMH levels or predicting POI in girls? Anybody can take the question. Hello.
Yeah. Actually, the recruitment of the follicles is starting very fast, and when the women's age over 15 years old, actually, when the patient already get her first menstruations. So that's why if in the patients with the POI, such as the Turner syndrome, yeah, her prognostic, it must be better when we preserve the ovary before she get menstruations, because the follicle is not recruited yet. But the very interesting question, when actually the appropriate time for us recommending the women to check ovarian reserve, it's not so easy to answer. I don't know when we recommend the patient, the women, to check her age before she got the menarche, or before 15 years old, maybe, because in the 15 they're starting the very fast recruitment of the follicles. Thank you.
Okay, thank you. And we come to the last question, Dr. Professor Ben Moll. Um, how to use FSH, recombinant FSH in couples with infertility due to decreased ovarian reserve, the dose, the number of cycles before going to ART. It's Santoso who's asking this question.
I mean, I don't exactly understand what is meant here with before going to ART.
That's what even I was concerned. What I think what he means is that you're giving simple treatment, you're giving them planned intercourse types. So can you use gonadotropins?
Yeah, I mean,
That is the question.
so one thing is really important. I showed this natural cycle graph not for nothing. I think it's really important to realize. And one thing we should not forget, and it maybe makes me unpopular, IVF and ICSI are invented in situations where the gametes did not meet each other, right? So the first woman undergoing IVF just had blocked or was operated on her tubes. And for ICSI, the sperm without ICSI doesn't reach the egg, so to say. So these are all kinds of techniques that help to bring the gametes together. But the problem in ovarian aging is different. The egg, apologies to all the women on the call here, the egg is just not good, so to say, in relation to age. And IVF is not solving that problem. Realize that, right? So I would be quite careful with, and I'm from a country where we do an enormous amount of IVF, and people seem to think that that's the solution for everything. But in older age, it isn't. And I haven't seen the trial that actually demonstrates that IVF in older women is increasing your cumulative live birth rate. So I would be reluctant to jump immediately to IVF. I would do IUI if you do that with Clomid or letrozole, etc. I would not use the more expensive gonadotropins here. And yeah, at some stage you might do some IVF cycles. The other thing to consider, depending on the patient's situation, is to do IVF earlier and freeze oocytes and or embryos. I mean, if you want to do a rational thing, that is something, but you shouldn't wait until 38 or 39 or 40, obviously, then it's not going to help. But that's the, sorry?
Time to pregnancy.
No, but in terms of freezing, I mean, if you want to fight ovarian aging, you should freeze earlier.
Right.
If that is a discussion that you can have with your patient. So I would really encourage people to keep thinking and ask yourself, where actually do I think that IVF in somebody who is 38 and has a regular cycle and has patent tubes and has relatively normal sperm is going to help me? I think that the data for that are very limited.
No. Thank you. Thank you very much. I think we've had a wonderful symposia and lots of questions, fabulous answers by all of you. Thank you so much. And thank you, Dr. Viveko, for involving me in this seminar. I think it was really very enlightening. I would like to thank all the speakers. Yes, you can take over.
Thank you very much for Dr. Nandita Parshekar, Professor Budi Weko, Dr. Miyuki Harada, and Prof. Benmo for the interesting insight on ovarian aging. I believe all the participants here today gain useful insight and knowledge on the topic. Before closing this session, I would like to invite Dr. Nandita Parshekar to award the certificate for all speakers involved. First, I would like to invite Dr. Rohana to receive the certificate.
Dr. Rohana, we would like to give you the certificate of appreciation for participating in the AO4 Campus 1.
Okay, thank you. Thank you, Nandi.
I'll take picture. 3, 2, 1. Thank you. And the second one, I would like to invite Professor Budi Wiweko to receive this certificate.
Professor Budi Viveko, thank you. And this is the certificate of appreciation presented by the AFOG Campus 1, signed by Dr. John Tate, Dr. Rohana Hatatua, and Professor Budi Viveko.
Thank you so much, Nandita.
Thank you.
Okay, thank you. Third, I would like to invite Dr. Miyuki Harada to receive the certificate.
Dr. Miyuki Harada, thank you for participating in this AOFOG Campus 1 on ovarian aging. And we would like to present the certificate of appreciation to you, signed by Dr. John Tate, Dr. Rohana Hatatua, and Professor Budi Viveko.
Thank you very much.
Thank you, Dr. Miyuki. And I would like to invite the next speaker, Professor Benmol, to receive the certificate.
Thank you, Professor Ben Mole. This is the certificate of appreciation given to you on behalf of AOFOG Campus 1 Ovarian Aging webinar, signed by Professor John Tate, President of the AOFOG, Dr. Rohana Hatatua, Secretary General, and Professor Budi Viveko, who's the Chairman of the REI Committee, AOFOG. Thank you.
Thank you so much. It's such a pleasure to be here. Thank you.
Thank you, Professor Benmol. And lastly, I would like to invite Dr. Rohana Hatatua to present certificate to Dr. Nandita Palshekar.
Thank you. Yes, I would like to thank Professor Nandita for very nicely conducting and moderating this session, discussion, and the lectures. It was so interesting and well moderated. And so we would like to present you the certificate of appreciation for being the chairman of this session of this Asia Oceania Federation of Obstetrics and Gynecology, this ovarian aging webinar. So over to you, Dr. Nandita Palshekar, this certificate.
Thank you. Thank you, sir.
Thank you, Dr. Rohana Hatatua, and thank you for Dr. Nandita Palshekar. Now we will take a documentation for the event. I would like to invite all speakers to open the video and also the RI committee. Professor Mukri Hamdan, Dr. Sumjit, and Professor Mejo Chen.
I'm not able to start my video.
Okay.
Please help Mukri to open the video. Help. Please help.
इसको पूछ के check.
I'm sorry,
Can
I'm
you
not
try it
able
now?
to open my camera.
Professor Mejo, can you try now? Try
Yeah.
again now.
Okay, I'll try again. Okay. I'm sorry, I'm not able to open it.
Okay. We have make you a co-host. Can you please start the video now? Okay. Thank you very much. I will count to 3 to take the picture. 1. Prof. Mejo, sorry. Prof. Chen.
Yes, I'm sorry, I'm not able to connect the camera. So go ahead. Don't care about me. Thank you.
1, 2, 3. Once more. One, two, three. Thank you very much for all speakers and the RE committee for organizing this event. I would like to remind all the participants to fill the Google form as listed in the screen in order to get a certificate for this event. The certificate will be sent through email within a month after the form was filled. This form is a mandatory in order to get the certificate for this event. With this as the MC, Master of Ceremony of this event, I would like once again to express our gratitude for all of your participation, and we look forward to see you in our next event. Thank you and see you later.
Thank you.
Thank you.
Thank you very much.
Thank you, everyone.
Thank you.
Thank you very much.
Thank you, everyone.
Bye.
Thank you.
Bye.
Bye-bye.
Bye.
Bye. Bye. Thank you.
Bye bye.